of tendon, and lastly enchondroma. And then we will have a question answer sessions where the participants will write their question in chat box, and we will ask our moderator, as well as I will also try to answer the questions. So I am sharing my screen and starting the PPT now. So like this is the case scenario. 34-year female, when she has pain in her right little finger since 1.5 years. She has consulted many doctors, including psychiatrist, and she has taken antipsychotic medicines for 10 months. And you can see she withdraws her finger when touched superficially and have extreme tenderness or extreme pain. So what can this be? Anybody? पेशेंट को उंगली पे टच करते ही सीवियर टेंडरनेस हो रहा है. She has taken antipsychotic medicine for 10 months. Yes. Swapnil Patel has replied glomus tumor. Yes, Swapnil, this is a glomus tumor, and so this also can be tumor. Yes. So we will talk about hand tumors, common hand tumors, which I have already mentioned: glomus tumor, giant cell tumor of tendon sheath, ganglionic cyst, or enchondroma. Tumor is classified into soft tissue tumors or bony tumors, and as well as benign tumor and malignant tumors. Malignant tumors, we are not dealing with them today. We'll leave them to our onco ortho friends. So in benign tumors, we have ganglionic, benign soft tissue lesions or tumors. We have ganglion, giant cell tumor of tendon sheath, or glomus tumor. And benign bony tumor, the enchondroma is there. These are commonly seen in hand. So as in any tumor examination, we have to identify the location, the size. We have to palpate the lesion, whether it is soft, firm, or hard. Then mobility with the tendon, like movement of finger, whether it is mobile or not, whether it is tender or not. And we have to check for distal neurovascular deficit, whether sensation or the capillary refill is present or not. In investigation, now we have a good investigation, but we have to start with X-ray, then MRI or sonography, and based on the lesion, we can do incisional or excisional biopsy. Excisional biopsy is a part of treatment as well. So first of all, we'll talk about ganglion, which is most commonly seen in our day-to-day practice. It is the most common hand mass, mucin-filled synovial cyst, usually attached with adjacent capsule, tendon or tendon sheath. And जनरली गैंग्लियन में हम लोग बोलते हैं कि कोई भी इडियोपैथिक है, कोई मतलब प्री इंसिडेंटल कोई इवेंट नहीं है, बट इन 10% ऑफ केसेस देयर इज ट्रॉमेटिक इवेंट और माइक्रो ट्रॉमा प्रेजेंट इन गैंग्लियन ऑल्सो. The wall of ganglion cyst is made up of collagen fibrils without epithelial lining, and the capsule around the ganglion, it is a tightly packed collagen fibers, sparsely cellular areas with broken collagen, and it is filled with mucin, which contains glucosamine, albumin, globulin, and hyaluronic acid. As we all know, most common anatomic location is dorsal carpal, which is arising from scapholinate ligament. Then the second most common is volar carpal. Then volar retinacular, means arising from tendon sheath, or it can be from the joint, distal interphalangeal joint as well. Mostly the ganglions are asymptomatic, but they can give pain. They can cause issues with cosmesis. There are very less chances of like malignancy, but patient is concerned that it may turn into malignancy. It may subside with rest and enlarge with activity and rupture or disappear spontaneously. In investigation, if it is ganglion can occur at any place in bone, in muscle, in from the joint. So if it is in bone, we can get X-rays done, and intraosseous ganglion are very appreciated on X-rays. But MRI is a better diagnosis to establish a diagnosis, and it presents as a low T1 signal and high T2 signal. As we all know, in treatment part, mostly it is non-operative, just observation and reassurance. It is first line of treatment. In other method, we have aspirations and instillation of lignocaine plus betamethasone, which is the second line of treatment. In volar ganglion, aspiration is avoided as there is a close proximity with radial artery. In operative treatment, it has adequate exposure to identify its origin and allow a resection of stalk and portion of adjacent capsule. As we have seen in its pathology, that capsule is also involved. Surrounding capsule is also a part of ganglion. So we have to excise around 1 to 1.5 centimeter capsule adjacent to ganglion. So what is my preferred method? I put transverse incision over the ganglion. If it is scapholunate ligament, then proximal carpal row. I go between extensor pollicis and extensor digitorum communis. The main cyst pedicle are mobilized down to the underlying capsule, keeping the wrist in complete volar flexion. We have to incise the capsule around the ganglion from its radial aspect and continue until all attachments to the scapholunate ligament have been excised. So we have to go around the ganglion and excise the capsule, and we have to identify the origin of ganglion from scapholunate ligament. Then here we can see the mucin filled duct is invariably seen. Attachment along the scapholunate ligament are also excised tangentially. We cannot go in scapholunate ligament. Otherwise, we may rupture or we may damage a scapholunate ligament. So we have to excise it tangentially. And after excising the ganglion, the joint capsule should be left open, should not be closed, and keeping the wrist in slight flexion, because after the excision of ganglion, the wrist flexion becomes a bit difficult for patient. So we immobilize them. This is the, I think, only condition where we immobilize the wrist in flexion, keeping the dorsal slab in 10 to 15 degree flexion. Volar ganglion, they arise from capsule of radiocarpal joint or scaphotrapezoidal joint, twinned with bifurcating branch of radial artery. It is mostly seen between the branches of radial artery. It looks small but can be extensive at this surgery because it arises from the volar ligaments. It may be extensive, and before excising or before attempting to excise the ganglion, we should do Allen test to check the continuity of these arches. Now, in treatment for volar ganglion also, longitudinal incision, particular care is to be taken for radial artery. Pedicle is traced to volar joint capsule, and ganglion has been excised and surrounding tissue can be compressed digitally. We can compress the surrounding tissue to rule out any further mucin-filled pockets. There are certain complications like in aspiration, there are higher chances of recurrence, marked subcutaneous atrophy and skin pigmentation, can infection or neurovascular injury. And when we excise, there are also still the chance of recurrence, but they are less in excision. Neurovascular injury in volar ganglion, radial artery can be injured. Then stiffness, as I have mentioned, volar flexion of wrist is reduced. tendon injury or troublesome neuromas. If we cut nerves or tendons, there are also chance of complication. So I think this is all about the ganglion. We have covered volar ganglion, dorsal ganglion, how to exercise. The certain important points were we have to exercise ganglion from its origin. First thing, tangential excision main. Then third is we have to keep the wrist flexed for to avoid the decreased range of motion for volar flexion. So these are 2-3 important points. Otherwise, in day to day our OPD we identify ganglion cases significantly. So the second most common hand tumor is giant cell tumor of tendon sheath, which is it is also known as pigmented villonodular tumor of tendon sheath. Our participants can write questions in chat box regarding ganglion. We'll take questions afterwards. So it is second most soft tissue tumor in hand. It presents in 3rd to 5th decade of life. It is most common on palmar surface of radial 3 digits near the DIP joint. The complaints are enlarging mass in last 1 year or 2 year, pain, worse with activity. When the size is increasing, patient may feel pain and there may be bony erosion also. So it is firm nodular mass that does not transilluminate as it is firm in consistency. It is slowly growing mass in hand, usually asymptomatic, but mass usually found in soft tissue near tendons because it arises from tendon sheath. Investigation, we can do X-rays to identify bony erosion, sonography, or most commonly performed is MRI. And treatment is marginal excision, but it is mostly near the distal interphalangeal joint. We have to be very careful about digital neurovascular bundle and mainly nerve. We have to take a Brunner incision, protect digital nerve, and excise adjacent tendon sheath from where this giant cell tumor has arisen. There are definitely chances of recurrence in presence of satellite lesion or incomplete excision. 5 to 50% recurrence chance is there, but if we go to origin and excise it, there are very less chances of recurrence. Joints or tendons may be involved and local recurrence is usually treated with repeated excision. This is about giant cell tumor of tendon sheath. This straightforward diagnosis. We can identify it. It is a spot diagnosis, and the treatment is, if it is symptomatic, it should be excised. If the size is increasing, it should be excised. Now, this is very important. Third thing, glomus tumor, which is commonly misdiagnosis. When this patient present to us, they have consulted doctors as well as they could not identify, even there is no external appearance of this tumor. So it is very important to know the clinical features of glomus tumor. So glomus cell, it is a kind of chemoreceptor in carotid bodies or aortic bodies. That is glomus cell. But what is glomus body? Glomus body is a component of dermis layer of the skin, and it is involved in body temperature regulation. The glomus body consists of arteriovenous shunt surrounded by capsule of connective tissue. So glomus body looks like this. It is a neuromyoarterial apparatus. Nerve is also involved. There are certain muscle and there are arteriovenous involvement is also there. It is mainly body's thermoregulatory mechanism. Maximum in fingers and toes, glomus body is found, and per minute circulation is 0.2 ml to 120 ml. It can regulate the body's temperature by circulating the blood. It has this much capacity, 0.2 ml to 120 ml. So I think my team is telling we are going a bit fast. So will is this fine, or somebody can write in chat box? Is this okay? I have spared session for question answer mainly. So I thought some theory part I will take. Yes, anybody has any doubt? Okay, thank you, sir. Neeraj Joshi sir is telling going good. So I'll continue and then we'll take question answer. Thank you, sir. Uh, yes, it is most common in hand, and most of the time it is subungual, means underneath the nail or nail bed. 50% of all lesions have erosions of distal phalanx, primary involvement of bone being very rare. It is not arising from bone, but it is eroding the bone. So the symptoms, as I have shown you in the video, there is extrinsic pain, severe pain, extreme tenderness to touch, cold insensitivity, small bluish nodule can also be visible under the nail bed. Small bluish discoloration is seen. Then it is often difficult to see, and especially in subungual region. That's why it is most commonly missed. And there can be nail ridging or discoloration. That is also common. So there are tests. If patient is having pain in nail bed region, there are tests named after a Love test, where we have to pinpoint the tenderness. Pressure to the area with pin head elicit exquisite pain, which is very much sensitive and it is quite accurate. That is known as Love test. We have to identify. You have seen that when I was touching the tip of that lady, she was withdrawing her hand. So this is the kind of pain just on superficial touch when patient withdraws the hand. It is there are high chances or more likelihood of having glomus tumor. Then this is another test, Hildreth test, where when we inflate the tourniquet, it reduces the pain or tenderness and abolish the tenderness elicited in Love's test. Because there is no blood circulation, the pain goes. It is also sensitive as well as specific test. But once you are aware of glomus tumor, that there is severe tenderness in fingertip, it is like more likely that it is glomus tumor. In investigation, when we can get X-rays done to see pressure effect on bone, or MRI for definitive diagnosis. The size of glomus tumor is very tiny. It can be from 2 to 3 millimeter to 1 centimeter. So for small lesions, it is better to get 3 Tesla MRI done, and we have to tell radiologist to look at particular site or particular location. Even in nail bed, we have to tell them radial aspect, ulnar aspect, subungual area, paronychial fold. We have to tell them like that. So treatment is obviously excision. It can be performed under general or regional anesthesia. Allows pin test to confirm the site of lesion. Double tourniquet technique. We have to in this glomus tumor excision, what we can do is we have to keep limb down and we have to inflate the tourniquet. So the lesion will be surrounded by blood, and then we can apply finger tourniquet. So the lesion will become bright when we will try to excise. Sometimes it becomes difficult to identify the lesion. So we use this technique, but in my personal practice, I generally don't use double tourniquet technique. We have microscope, and it is better to excise glomus tumor under microscopic vision. So the marginal excision is the treatment, and there are 20% chances of recurrence. Recurrence, infection, and nail bed deformities are the common complications. I have certain videos. Here we have removed the nail bed. We have removed the nail bed and we have incised, we have removed the nail plate and we have incised the nail bed, and we can see there is a glomus tumor coming out. Yes. So that is very soft tissue mass. It is difficult to identify or differentiate from surrounding tissue. It is almost of this size only, 3 to 4 millimeter maximum. And it gives extreme relief as well. जितना टेंडरनेस था उतना ही रिलीफ इमीडिएट मिलता है पेशेंट को. So this is about glomus tumor, and this is our patient which I have shown you earlier. She was withdrawing completely. We've excised the glomus tumor. And she's telling her journey, but we'll see her movements basically. Movements as well as now you can see she can touch her finger nicely. She has no pain. This is very rewarding surgery. Glomus tumor identification or diagnosis of glomus tumor and treatment, both are rewarding. Yes. Coming to our last topic, that is enchondroma. It is common primary bone tumor. 90% of bone tumors in hand, proximal phalanx is the common location. Localized swelling, which may be painless, or pathological fracture associated with minor trauma. It is diagnosed as an incidental finding on plain radiograph. It can be asymptomatic, discovered incidentally, or it can present with pathological fracture. In physical examination, there can be diffuse swelling, or there are multiple enchondromas which may disrupt growth plate or angular deformity in inherited diseases like Ollius disease or Maffucci syndrome. In investigation, X-rays, bone scan, and MRI to confirm the diagnosis. Treatment is non-operative or operative, where mostly it is non-operative in asymptomatic enchondromas. We have to take serial radiographs 6 monthly or 12 months to confirm radiographic stability, and long-term follow-up for patient with multiple enchondroma syndromes like Maffucci or Ollius syndrome. In operative, the straightforward treatment of enchondroma is curettage. Curettage with bone grafting, mostly autologous bone graft, or we may use some other substitutes as well. Curettage and bone grafting is used for symptomatic lesion, for pathological fractures, and nowadays immediate curettage with grafting with fracture fixation is also preferred. There are chances of malignant transformations, and larger lesions are at risk of recurrent fractures. So, just to revise, ganglion, mostly the treatment is important. So for ganglion, we excise ganglion only if they are painful, if the size is increasing, and third thing, if they are arising from joint capsule. That is about ganglion. Then third is giant cell tumor of tendon sheath. We have to take care of digital nerve. Then third is glomus tumor. Diagnosis of glomus tumor, severe tenderness on touching fingertip, and the excision of glomus tumor under microscopic vision. Those were important. And in last, enchondroma, curettage is the treatment. So the take-home messages are: ganglion is most common tumor, reassurance for ganglion, tangential excision important, confirm its origin on MRI. Ganglion is not clinical diagnosis. We have to identify the origin of ganglion. Take care of neurovascular structure while excising the giant cell tumor. X-rays are needed to identify pressure effect of tumors. Extreme pain with cold sensitivity in glomus tumor excision under microscope, and chondromas to be observed in asymptomatic cases, and intralesional excision and bone grafting is recommended. recommended method. So with this, I complete my talk, and from now onwards, every third Thursday of every month, we are introducing the hand clinic, and we will present webinar on basic hand disorders. Every third Thursday of every month, just like this, morning 8:30 to 9:30. And our next topic will be Kienbock disease. Thank you. So now I will open the chat. अनम्यूट करना पड़ेगा दीपक सर को अनम्यूट. दीपक सर आप you can unmute yourself.
Right.
Yes.
Can you hear me?
Yes, sir.
Okay. Wonderful talk, Dr. Karan.
Thank
It
you, sir.
was quite precise, illustrious, and covering all the points. So let us take questions one by one now. So because you presented ganglion first, and it is also most commonly encountered tumor of hand, let us take questions on ganglion.
Yes.
And there is one question in the from Dr. Chetan that he has not seen ganglion tumor. Please repeat ganglion tumor slide. He has missed it.
Okay.
Can we do it?
Sir, one second. We can do.
Or else we can take during questions also.
Yes, sir. Sir, another question from Dr. GP Singh, sir. Have tried aspiration and installed of tetracycline in ganglion. It works well. He has a nice insight, but sir, have you ever tried tetracycline installation in ganglion?
So actually, I generally don't operate ganglion, and patient who just demand they need excision, they demand treatment. The only thing I try is surgery. I don't like offer them any treatment with injection or putting something inside. So I have never tetracycline. This is new thing for me.
Okay. Hello. Deepak sir. Yes, yes.
Hello. Yes.
Yes.
So this is new thing for me. New thing.
To me as well. But there are multiple methods in treatment of ganglion. In ancient days, they used to hit Bible on ganglion and just burst the ganglion. I think that
Yes.
is also one method. So, yeah,
Actually, thing is like aspiration and injecting something into it, the recurrence rate are really very high, 50%. So any procedure with 50% of recurrence rate, I feel it is better to be avoided.
correct, sir. We had yes, GP Singh sir is telling threading was also used. They used to thread as
Yeah,
well.
yeah. These I am aware of threading, but the only thing is recurrence.
Hmm.
So in private practice, like patient coming back for same problem, it does not send good results. Always better do something which has got good results.
Yes. So, sir, there like in basic hand course, Dr. Anil Bhatt sir has come, and in Gujarat at least we have practice of ganglion being operated by, like in civil hospitals, ganglion being operated by first years or second year or maximum third year residents. So when I told this to sir, sir told no, in our setup ganglion is to be operated by senior surgeon only. It is the case because like.
Completely.
Uh,
I completely agree with you. Ganglion is the most difficult tumor of the hand.
हाँ.
To find the planes, to find the stalk, to trace it to the capsule, which you have explained very beautifully. So it is one of the most difficult tumor to excise. And mind you, while the beauty of excising the ganglion is like excising it wholesome. So it
Yes.
should be always our goal that we should not puncture it.
Yes.
The moment it punctures, the joy of the surgery is gone.
Yes.
So when you try to excise it completely, if you excise ganglion completely, then that means you are becoming a senior surgeon.
Our Neeraj Joshi sir is quite senior in Gujarat. He has told that if you operate ganglion with major surgery mindset, at
Yes,
that point recurrence rate is low. So he has mentioned the same thing, I think. that we are talking about.
Totally agree. Totally agree.
Yes, sir. Hmm. Uh, yes,
One
sir.
another thing, uh, I will ask Karan,
Yes, sir.
what investigation do you prefer for ganglions?
Sorry, sir. What investigation? Yes, yes,
What,
yes.
what investigation do you prefer, like before
Sir,
operating them?
sir, in my routine practice, what I do, what I tell people, patients is इन गैंग्लियन में तीन ही चीज है। पेन, अगर एसिम्टोमेटिक है, पेन नहीं है, साइज नहीं बढ़ रहा है, तो कुछ नहीं करना है। अगर उनको पेन है या फिर साइज बढ़ रहा है और एक्सीजन की तरफ अगर हम जा रहे हैं, तो आई जंप टू स्ट्रेट फॉरवर्ड एमआरआई। फर्स्ट
Okay.
स्ट्रेट फॉरवर्ड एमआरआई एंड ट्राई टू कन्विंस पेशेंट अबाउट थ्री टेस्ला एमआरआई टू आइडेंटिफाई द ओरिजिन, एग्जैक्ट ओरिजिन ऑफ गैंग्लियन।
Yes.
So it is my
Yes,
preference.
that's right. Actually, so whenever we are trying to do any intervention, it is always better to do an MRI. And
Hmm.
other thing, like many times, like it originates from the STT joint. But if you see the nodule, you see the actual swelling, it will be quite proximally or distally. So
Hmm.
it is always better to do MRI from where that swelling is arising, from that where that stock is going to, so that it becomes easier to plan also.
Correct.
And many times they have like a lot of satellite lesions which are communicating with each other. Like one case I had, which there was a like the swelling was quite obvious on the dorsal side, but then the underneath it was extending almost on underneath the sensor compartment. So if I had not done the MRI, I would have completely missed that. So it is always better to do an MRI before doing any kind of intervention.
Yes, sir.
Another case is like in cases of like dorsal ganglion are quite common, and there is one more syndrome which is called as dorsal wrist syndrome. We have to be careful about that. So in those cases, we have to look for increase in the scapula unit gap. So many times carpal instability might present with a occult wrist ganglion on the dorsal side. So in that cases also X-ray becomes mandatory, and we have to deal the underlying cause also.
Yes.
And another thing you mentioned that mucin cyst around the DIP joint. So
Yes.
these are called as Haberden nodes.
Yes.
So whenever we are excising that, we have to be careful that the osteophyte which is there had to be excised. If we just remove the cyst and we do not remove the Haberden like that osteophyte, it is bound to recur. So that thing has to be kept in mind. That we have to remove osteophyte also. So in such cases, X-ray even becomes mandatory.
It is most commonly associated with osteoarthritis of DIP joint.
Yes, yes, yes,
You have to exercise the osteophyte. Correct.
yes.
Is there any other question regarding any other topic like ganglion or giant cell tumor of tendon sheath, glomus tumor? Somebody has asked about recurrence in glomus tumor. Dr. GP Singh sir has asked about recurrence in glomus tumor. Your insight, sir. First, you tell. Recurrence in glomus tumor. When there are chances of recurrence in glomus tumor?
So yes, as you have mentioned, theoretically they always mention around 15 to 20% chances. But then if you use good loop microscope, even that chances of recurrence are even lesser. I feel in my practice.
Yes,
So
sir.
if you do it under microscope, the chances of recurrence become less.
Have you ever encountered any recurrence in your practice in glomus tumor? Because I have not seen.
Uh, Sir, I have yet to see, but
Uh,
then
there are always
it
chances.
is not like that. That no follow-up is not always a good follow-up.
Yes.
But yet I have to see recurrence of glomus tumor.
Okay. Any of the participants want to unmute themselves? Please tell us in chat so we can unmute and you can ask your question. There are no questions coming, so I think that will be better idea.
That's something like what I have encountered in my practice. Like whatever written in books, like patient has in cases of glomus tumor, so they say immediate relief, but that I have never seen in my practice. So whenever I operate on glomus tumor, I always tell them that it will always take around 6 weeks for pain because the surgery pain, or something pain which they are habituated to. It always remains there, lingers on. So by the end of 6 weeks, they are completely off pain. I have made a practice. Pre-operatively, I counsel them. It will not be an immediate relief. It will almost take 6 weeks. So what is your experience, Karan?
Sir, actually, I have got good insight from you, but I tell patient that you will have a immediate relief. Surgery pain will
Okay.
surgery pain, some pain will be there.
Okay.
There is little known, like we can say 50% of difference is there in surgery pain and glomus tumor pain. Patient immediately identifies that this is a surgery pain or this is glomus tumor pain. Patient will feel less
Okay.
physically.
Okay. Okay.
But I will take care. I will tell patient only 2 to 3 weeks now onwards.
Okay. Yeah. Okay.
Yes. Uh, Sir, what do you prefer? 3 Tesla MRI or 1.5 Tesla MRI for glomus tumor? Or based on availability, I think Akola has this 3 Tesla MRI.
Yes, we do have a 3 Tesla MRI. And what I have seen, like it has been there since 1 year. Before that, we had an 1.5 Tesla, and I never had an issue. I never had an issue. But
Hmm.
certainly, 3 Tesla has a like one level up. It shows even clearer images, better, even small tumors can be detected. But frankly speaking, like even 1.5 Tesla, we did not have any. I think it's more radiologists who has a keen eye.
Yes, sir. Like once diagnosed as a glomus tumor, then we can clinically also like
Yes.
go around. Uh, so for enchondroma, when do you operate
Yes.
enchondroma?
So most yes, that's a very good and like tricky question. So in chondroma, mostly patient will present with a pathological fracture.
Okay.
Pathological fracture. So we have like the protocol is like we wait for fracture to heal for a month, and once the fracture heal, we do a biopsy first, and then do a curettage and bone grafting.
Okay. Okay. And fracture conservatively treated. Conservatively.
Yes,
Okay.
they have a very good healing potential.
Yes.
A simple body stepping can heal the fracture.
Dr. GP Singh sir has some insight. He's telling we have operated in missed tumor in surgery in a case of thumb glomus tumor. We did wide excision and patient was fine. Yes, sir. Glomus tumor excision is the treatment. Marginal excision is the treatment. But you have done wide excision. Obviously, it is like better and the patient is fine. That is good. The diagnosis of glomus tumor is important. Many a times it is missed. So, what is the percentage or what is the prevalence of missed glomus tumor coming to you? And you in straightforward in first OPD setting itself, you have told that this is a tumor. You get MRI done and you will get rid of it.
That many times, actually, what mind doesn't know, the eyes won't see. So, if you don't know that this can be a glomus tumor, it will always be missed. So, there are many times, as you had shown in your case, that it almost taken for a treatment for a year. So similarly, we also get patient like everywhere they have done MRI, cervical spine, nothing happens. So 50%, I think, but then like now the chances of misdiagnosis becoming lesser and lesser because of webinars, talks, and people are educated now.
Yes. See, sir is telling we have seen a patient, like we have seen a case of ulnar nerve anterior transposition done in missed diagnosis of glomus tumor. So
Yes, yes.
everything is tried.
Any- Anything can happen in glomus tumor.
So my patient was stamped a psychiatric case and she has taken antipsychotic medicine for 10 months.
Yeah, many people like patient will tell you amputate my finger.
Ampute my finger.
Yeah. The kind of pain, or they will have suicidal tendencies also.
Yes, yes, yes. Because nobody is able to diagnose and patient only herself or himself is feeling the pain. So,
Yes,
so to our participants, the diagnosis of glomus tumor, just we have to keep in mind, that's it, that glomus tumor can be.
yes,
Uh, for GCT, giant cell
yes.
tumor and sheath, do you do? needle biopsy in all cases, any case?
So, like what I have seen, if there are bone tumors, I will always do a biopsy, which we call it as incisional biopsy. In cases of soft tumors, soft tissue tumor, what we do, like what we tell patient, is an excisional biopsy. Like we will remove the tumor en mass and we'll send it for histopathological examination. And then whatever comes, like if it's a benign tumor, the treatment ends there only. And if it's a malignant, then we have to do further investigation. That way we are safe also. So the procedure is called as excisional biopsy. So
Okay.
we do not do a FNAC or something like that. We just do an excision and we send it for biopsy.
So, like, this is like my question or my curiosity. Like, have you ever encountered a giant cell tumor? You have diagnosed it as a giant cell tumor, and it turned out to be malignant tumor on biopsy. Anytime?
Not yet, not yet, not yet.
Okay. Because we are anyway getting MRI done before proceeding to
Yes,
any
yes,
procedure.
yes.
Yes. Hmm. Yes, anybody? Dr. Chetan sir was telling ganglion slide, he has missed. So we'll do. Sir, what regarding ganglion? पूरा स्लाइड प्रेजेंट करना तो थोड़ा डिफिकल्ट हो जाएगा बट एक 1 second. What regarding ganglion is he had some question. Please repeat ganglion tumor. Dr. Chetan sir, you can unmute yourself and ask any question regarding ganglion. Dr. Chetan, Dr. Sriram, Dr. Ramesh Chaudhary.
I
Ramesh
have,
bhai,
sir, I have missed the lecture about the ganglion. That's why I am asking you.
I'll do one thing. I can share a PPT with you, but repeating the talk will be a bit difficult
Okay,
because.
okay, you can share the PPT.
Okay, but if you have any question regarding ganglion, you can ask. The Dr. Deepak sir is also here. I may also answer. Dr. Ramesh Chaudhary sir. It's okay. Before, if somebody has no question, I'll ask. Sir Deepak sir, have you ever used? Okay, from to all participants as well. Anybody is using steroid for ganglion cyst? Steroid? Deepak sir, to you as well. Steroid. Yeah, you are not audible, sir. Sir is not audible. Why? सर यू क्या हुआ चैट बॉक्स? सर आपका माइक एक बार देख लीजिए। हाँ, आपका माइक बंद है सर। हाँ, यस, ओके। नाउ यू कैन अनम्यूट योरसेल्फ। हाँ,
Okay.
यस।
The host is not allowing to participate.
सॉरी सर।
Now I hear me.
आई कुड नॉट
Hear
हियर।
me?
I could not hear you last 2 3 words. Have you ever
Can
used?
you now?
Now, yes, absolutely fine, sir. Steroid. Have you ever used steroid for
Sir,
glomus?
I do not use steroid anywhere.
Anywhere?
The
Oh,
reason being, anywhere. In ganglion, inadvertently, the steroid spills. And
okay.
wherever it spills, it causes subcutaneous atrophy and
Oh,
pigmentation. So
sir.
it looks like vitiligo.
Really?
So patient can trouble you for that. So I refrain myself for putting steroid, and plus over that, it has got a 50% recurrence rate.
Okay.
So I do not.
Okay. Anybody from our participants? I think one question is there from Dr. Ramesh Chaudhary. 1 or 2 times excise the smaller one. Don't have much experience on it. I think he has told about glomus tumor mostly.
Yes.
Uh, uh, yes, sir. And have you ever? Oh, he is telling about ganglion itself. No, one or two times excised, smaller one, don't have much experience on it. Regarding ganglion, he was telling, and GP Singh sir is telling use Placentrex gel for depigmentation after steroid injection. Yes, can be used, sir. There are different methods of practice and preferences.
Yes, definitely. So I don't use steroid, so I will. But that is nice insight, I think. If any of my friend uses, I will tell them use Placentrix.
Yes. Sir, have you ever encountered a patient with like scapholunate, ganglion cyst, damaging scapholunate ligament, and you have to reconstruct, as I think you have mentioned, of
Yes.
scapholunate joint space.
See, this is like I have seen one, but then the patient did not turn up for surgery.
Okay.
So, like I have like minimal pain, so he was quite reluctant. But then definitely patient had a scapholunate
Dissociation was.
increased wide gap, and he also had a dorsal wrist ganglion. So we have to be careful. We have to be careful.
Okay. What other kind? What is your like percentages of patient coming to you among these three, four uh, tumors: ganglion, glomus tumor, giant cell tumor, and enchondroma? Like, what is the percentage of patients coming to you?
We have not counted, but then quite a significant chunk, like quite
Not
a significant chunk. Ganglion is, I think, it is really very common, and glomus tumor, I think, one case in 2 months, I get like 6 in a year. Encontro was also same thing, and GCD is a little bit commoner, little bit common.
Yes. Okay. Dr. Chetan sir has told to keep these lectures at 9 a.m. 8:30 a.m. So it is difficult for us to. Anyway, we'll take care, sir. Next time we'll see something, and we'll do one thing. We'll take some questions before as well, and then we will start presentation.
Okay, yeah, that is a nice thing. Fine.
More than presentation, Dr. Deepak sir is here. You can ask questions to him as well. He will give you practical insights. So what I have in lecture, it was all theoretical part. So if you have any question regarding any of case scenario you have come across, you can ask to Dr. Deepak sir or to me as well.
Yes, and one more thing, like the ganglion which arise from tendon sheath, they are really easy to excise.
Yes.
That is really real joy. But the moment the stock goes to the joint, it becomes really tricky. So you have to be careful.
Dr. Deepak sir is Dr. Deepak Malokar. He is from orthopedic background. He has completed his undergraduate and postgraduate from KEM, Mumbai, and then he has completed his FNB, Fellowship National Board in Hand and Microsurgery from Ganga Hospital, Coimbatore in 2017. Now he is practicing hand surgeon at Akola, Maharashtra, and he is my senior. So I have invited him for the talk. You can ask questions. He is a very good hand surgeon in Akola, Maharashtra. Yes, sir. We were about ganglion. So as it is arising from tendon sheath, it is easy to excise.
Yes, and second thing, like whenever the volar wrist ganglion, the incision has to be like there are 3 wrist ridges on the volar side. So whenever we are taking the incision for excising the volar ganglion, it has to be a zigzag shape rather than a straight incision. Because if you don't follow these principles, the patient will have a scar which will almost look like the size of the ganglion cyst which was there. So he's got rid of the problem. Now he has got another problem. So whenever we are taking an incision on volar side of the wrist, we have to follow the principle that never cross a wrist crease in a perpendicular fashion. So it has to be in a zigzag manner. So that thing has to be encountered. That thing has to be followed very diligently.
Dr. Govind Purohit, sir, he is a quite senior orthopedic surgeon in Gujarat. He has also joined. Sir, uh, you can unmute yourself and give your insights. You just joined, but you can share your experience about hand tumors to us as well.
Good morning.
Good morning,
Good
sir.
morning.
Am I audible?
Yes,
Yes,
sir.
sir.
Yes, sir.
Yeah. Good morning,
Good morning, sir.
Dr. Karna, Dr. Deepak.
Sir, good morning.
Actually, I could not get the link. I was busy with the swimming. Then I started at 8:35, but I could not get the link. I
Okay.
reached the hospital and I was very eager to join the group.
Okay,
And
sir.
I am having more than 40 years of the multi-speciality orthopedic approach, where we have done quite a few tumors of the hand, like osteoclastum of the lower end of the radius, osteoclastum of the metacarpal, where excision and reconstruction by bone graft has been done. Even some of the cases, wrist arthrodesis, we have done. So shoulder tumors also we have done. Of course, it is not included in the hand surgery, but it is good that you have conducted a very good hand tumor webinar, and it will be for the benefit of all. Thank you all. Please continue.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you.
Yeah, thank you. Thank you.
Yes, sir. Sir has nicely mentioned osteoclastoma and of lower end and all. So, your experience about the tumors other than these four, like or you send them to ortho-onco guy, ortho-onco friend.
So
Anything?
GCT of the like distal end radius, then GCT of metacarpals. Yes, they can be managed very well, but more than that, like any kind of malignant lesion, it is always better to be dealt with by an oncologist surgeon.
Yes. Okay. Done. Then any other insight from any other or our participants? I think I'll unmute. Now everybody can unmute themselves and give feedback as well. If anybody wants to give feedback, sir, how did you like? This was the first
Dr.
time.
Deepak, Dr. Deepak,
Yes, sir. Yes.
am I audible?
Yes, sir. Yes.
One experience about the lower end of the radius GCT, I would like to give my opinion. Nowadays, live fibular bone graft are being used, so there is no problem of the union. But what we were doing, the free fibular graft along with the head, so which was fixed to the radius with the plate.
Yes.
Distally, we used to put K wires. So what we started using, that we should do fibula and wrist arthrodesis. So from their side, the union first starts. Otherwise, the problems of the subluxation or dislocation sometimes are more. And the
Okay,
union
sir.
rate is also better with the wrist arthrodesis. This is what is our experience we are saying. What is your opinion in this respect as far as the free fibular graft, not with the vascular, but the avascular we were using previously?
Yes, sir. Definitely. What you are saying, the same thing I am also using. But
Okay.
instead of arthrodesis, we are just like what we do, the collateral ligament on the fibular end, we take a stump of it, proximal end. And the same thing that is sutured back to the dorsal wrist capsule and volar wrist capsule, whatever we have been remaining. So that does the job. So I have never done an orthodesis in these cases.
But arthrodesis will help in revascularization of the fibular graft. That is what I believe.
We have actually used 7, 8, 10 centimeters of fibula, and all have united. They have a little bit of like what they say, a pain on the distal side, but then survival has never. I almost have a 7 years follow of 2 cases.
Yeah.
They're doing well. They are doing well.
I have 20 years of case.
Okay.
Lower the radius. 20 years old patient has no problem.
Yes, sir. Yes, sir.
Yeah.
Okay.
Even metacarpal GCT also very interesting surgery.
Yes, sir.
and
Very,
total
very
excision
interesting.
and replacement by the metatarsal. It is also very interesting surgery also.
Yes, sir.
Yeah.
Yes, sir.
Yeah.
Definitely. Definitely.
Yeah.
Yes, sir. Deepak sir, how was your experience? You also tell. This is what for the first time I have done this webinar and keeping one
Yes. Yes, it is really nice. And like our sir, SRS sir used to tell, you have to read when there is no need to read. So I think you have to listen also when there is no need to listen.
Correct.
So I think it is always good to go back to academics. And today also I has like I learned a lot from this presentation. The Hildreth test I was not aware of.
Okay.
So next time a glomus tumor comes, I will definitely do it.
Ah,
And
Actually, I would like to share one thing as far as glomus tumor is concerned.
yes,
Dr. J.C. Tarapurwala from Bombay
yes, sir.
is the one of the senior most who is doing, who I think where he is, I do not know, but he was the based in the glomus tumor surgery at that time. He took a
Okay,
lecture in Baroda. Actually, I am
okay.
facing glomus tumor in my left middle finger for last 60 years, rather 55 years.
Ore
Now
baap.
I do not have any problem. Initially, every day, 3 to 4 times, I used to get the whole body that electric current like situation. Now it has reduced to 3 to 4 times a year. So it is accommodated by me. I did not want to do any surgery as far as the glomus tumor was concerned with my middle finger.
Okay,
So
okay.
this is
So
my
that means,
personal
sir,
experience
a
to
strong willpower
yeah.
is also a treatment.
Yeah.
this is very
Even
interesting.
before 6 months, my wife had DQ. I
Okay,
told them, you keep patience, courage, and pain tolerance. Now, yesterday she was telling that it has subsided completely.
No, but the,
Yeah.
sir, DQ may subside, but sir, this glomus tumor, this is very interesting to know
Yeah,
how
glomus tumor has not subsided. I told them three
but
to four times in a year. If it touches very hard, then it creates problem. And now there is no problem as such.
no, but sir, have you done MRIs before? Now the size has
No, no, I am not MR, but that pinpoint and that thing, that
okay,
sensation
okay,
if I press it very hard over
okay,
that
okay.
point, actually. Yeah. And it was diagnosed by Dr. J.C. Tarap. Oh, yeah, he was very happy. You need a surgery. At that time,
Okay,
he
okay.
told me. So the diagnosis was confirmed by him, actually.
okay, sir, okay. But now there are certain objective tests. So if you have pain for like ભગવાન ના કરે એવું કઈ થાય પણ if it happens,
ના પણ મારા 50 વર્ષ તો નીકળી ગયા એમ જ.
yes, sir.
Sir, I must say you have a very high tolerance level
Yes.
because
I
glomus tumor is really, really problematic.
during chikungunya, I had PID with left side foot drop for 8 months.
Oh my
And I
God.
was not able to sit for 3 days on the toilet seat. Still, I went to Rajasthan by self-driving with the lumbosacral belt. See, tolerance is the only way to be happy in the life.
Okay, wow.
Okay, okay.
Physical, mental tolerance. This is the most important point.
Yeah, that's really nice, sir. That's really nice.
Yeah.
More than academic, this is like life learning lesson.
Yeah.
Philosophy also.
Yes.
Yes, sir.
See, patient is, we are fear, the problem of fear of pain is heresis, not the actual pain.
Yes, sir.
દુઃખ કરતા દુઃખનો ભય વધારે મારી નાખે છે આપણને
Yes,
કે
sir.
આમ થશે એકચ્યુઅલી
Yes, sir.
દુઃખ કરતા દુઃખનો ભય ઇન્જેક્શન લેવાનું હોય પરીક્ષા આપવાની હોય તો એનો ભય વધારે મારે છે પરીક્ષા આપ્યા પછી એમ થાય કે એમાં તો કોઈ તકલીફ જ નહોતી ઇન્જેક્શન લીધા પછી કે આ તો દુખ્યું જ નહીં. This is the psychology of the human being, actually.
Yes, sir. It is as it is 9:32. We'll conclude, but before yes, Deepak sir, your last insights regarding the session, not like about again.
Yeah, it is really nice.
Is this session available on YouTube to review?
Sorry, sir, PPT.
This Zoom meeting is available on
Yes,
YouTube
sir.
or not?
We have
Because I have missed almost 60% of the meeting.
We have recorded. We'll try to put it in on YouTube, or we will try to send you, sir. This whole.
Okay. Thank you very much. I will be highly obliged by you.
Thank you, sir. And
wish you good luck all for the super speciality which you have taken in your life, and you succeed more and more by academically, professionally, and by all means.
Thank you, sir.
Thank you, sir.
Thank you, sir. Yes, sir.
Thank you. Okay.
It is really nice initiative, Dr. Karan,
Thank you, sir.
and I am really happy to be part of it. And definitely, it will increase the awareness of the hand surgery and the pathologists. And I will definitely be try to part of it in future.
Thank you, sir. When I thought for first time about this webinar, you was the first person that came in my mind that I can contact. Yes, sir. Thank you.
Okay, thank you. Thank you.
Okay. Thank you to all our participants, and we'll connect on next month's third Thursday with
Okay.
Okay. Thank you.
Thank you. Thank you. Thank you. Thank you, everyone.
Bye. Good day. Good day to everyone.
Good day. Good.